Our next one here is on neurodevelopmental disorders. And this is another one of those categories where they've moved a lot of stuff around, changed a lot of names. And they're called neurodevelopmental disorders specifically because these are things that are usually identified fairly early on in life, though there's going to be sort of a massive asterisk behind that because there are a lot of biases in diagnoses for these, especially between the sexes. So oftentimes we'll find late life diagnoses, especially for women, for both autism spectrum disorder and attention deficit hyperactivity disorder. So it seems kind of weird that they're called developmental disorders, even though they are something that's sort of lifelong. There are others that fall into this category, but again, hitting the high points. So autism spectrum disorder is one of those that's been changed a lot recently. Again, sort of folding in multiple different specifically named and separated out disorders or categories and putting them all under this one umbrella and showing that sort of spectrum idea to try and capture the fact that there's a lot of variation within that specific category. And then attention deficit hyperactivity disorder, if you go back far enough, that would have just been called ADD because they skipped out on the hyperactivity component. But nowadays we'll use ADHD, though I believe ADD is still kept as a subcategory if you're lacking the hyperactivity component. But again, as time goes on and as the research finds more of the underlying sort of maybe mechanisms, as well as some of the different ways to categorize behaviors, they add a lot of complexity and make a lot of changes. So when we look at autism spectrum disorder, this is going to show basically extremes here, hence that spectrum idea. So you can have poor communication skills, and for some individuals, language development can be impaired. They might take extra years to learn how to speak, or might never really get into verbal communication at all. Or you can have other individuals still within the same diagnostic category, but who have maybe above average communication skills. Again, very varied in terms of what we'll see here. That's why we need multiple things to evaluate to determine a diagnosis, and also why it was so complicated and such a mess to try and put it together for a revision of our diagnostic manual. You can have lack of social responsiveness or variations in social interactions. So things like having difficulty with eye contact, maybe having difficulty with empathy and connectedness with others. There's some very interesting research that's been looking at specifically our mirror neurons. So if we haven't talked about them before, or if you've forgotten them, mirror neurons are neurons in our brains that tend to activate under two conditions. One is when we engage in particular actions. So we're actively doing something, those parts of the brain light up. They will also activate when someone else is doing something and we witness them engaging in those actions. The main theory is that that's something that facilitates the development of empathy. So I can see somebody engaging in these actions, so I can put myself in their shoes because I can imagine myself doing that action too, because my brain is reacting in a very similar way. And this is something that's been studied originally in monkeys, where they had a lot of things like grasping specific tools in specific ways, and they realized that they responded to their trainers also gripping tools in those specific ways. But as our brain imaging techniques have gotten better, we find that we can look at human mirror neurons. And again, we have to stick with simple actions, but we do find variation in activation for those diagnosed with ASD. So in that case, they've proposed that that lack of mirroring recognition with the action of others can make it difficult to understand that others are having their own experiences that we can relate to. And sometimes that gets tied into things like maybe difficulty with theory of mind questions, though that's more of an older idea where more recent attempts to study theory of mind have found that if you word it in a way that is relevant to that individual, a lot of those differences that used to be observed with our standardized theory of mind test, a lot of those differences go away, or at least are much less extreme than they used to think. So again, lots of differences as time goes on and as our research methods improve. You might also find repetitive or stereotyped behaviors. Routine and repetition can become very comforting, and they could be things that you engage in fairly often. especially if you're in a stressful situation. These repetitive behaviors might be something that are engaged in a lot more frequently. And some of them can be not so obvious. They can be things like skin picking or brushing the back of your neck, things like that. Or it can be something a lot more obvious and sometimes a lot more harmful. So there could be things like, say, hair pulling. So pulling your hair while stressed about something could fall under this category. And then at the end here, we have atypical thought patterns. And this is just sort of very different ways of thinking and different ways of having sort of electrical activity move between our hemispheres, especially. So this might relate to the fact that when we do sort of longitudinal brain scan studies, looking at children and seeing as they've grown up, have they been diagnosed with ASD or not? Children with that diagnosis, if we backtrack and look at their brain scans from early on, we'll actually find that their brains are a lot larger before the age of 4 years. And they're also going to end up showing higher levels of neural pruning once they've reached past that point. So if we remember back to our development idea or our development chapter, we talked about we make more neurons than we need, and we make more connections than we need to make sure that we have some redundancy to account for mistakes, and then we get rid of whatever's not necessary. They seem to make even extra connections if that pattern holds. And then they prune more because they need to get rid of even more extra connections. This can maybe be linked to the fact that we see atypical development in the cerebellum, which might relate to things like difficulty with balance and movement, but it might also explain why repetitive movements, especially things like rocking motions, might end up being comforting because it's maybe stimulating areas of the brain that are a little bit different than in a typical individual. We also have some atypicalities in hemispheric connectivity, so how information moves from one hemisphere to the other, basically where you can recruit multiple areas in a slightly different way, as well as some differences in the prefrontal cortex. But in a lot of these cases, these are still early results and something they're still following up on. This is another one of those cases where if we think back to the fact that the DSM-5 came out in, I think it was 2016, anything that was published in terms of research before that was done with different labels, and some things may or may not have qualified under this particular diagnostic heading. So if you're trying to do research and you're looking back on older research, you have to actually consider the fact that the diagnostic labels have changed, and some things that maybe used to count for a particular label maybe don't any longer, and maybe stuff that didn't count does now. So you have to worry about stuff like that. As a researcher, things like that make it extra complicated to look back in time. But obviously, I can keep sort of tangenting on that one, but I should not. Very briefly on attention deficit hyperactivity disorder, or ADHD. This one is recognized as having sort of two sets of symptoms. So attentional difficulties, hence the first part, and hyperactivity and impulsivity, which is the second part. And you can also have combined type ADHD, which is when you display symptoms of both. So some individuals can just have difficulty studying. So maybe they can't focus. Maybe they're easily distracted. Maybe they're going to have an inability to decide what they should be paying attention to. If you get into things like, I just finished teaching a brain and behavior class, and we talk a lot about things like assigning stimuli from our environment importance. So we have lots and lots of pathways, and I think we've talked about things like our reticular formation or our reticular activating system, two names for similar areas. That's all about filtering information as it comes up. And a lot of the proposed theories for at least attentional stuff with ADHD is an inability to decide what should and should not be flagged as important. So you sometimes end with everything being flagged as important, even if it shouldn't be. And in that case, you can end up being overwhelmed with stimuli in your environment where I'm trying to focus on this one thing, but also there's a bee over there and I have to pay attention to that sound. And the air conditioning system is on, and that's a different sound. And all of these things can start pulling your attention. So obviously can have effects on things like your occupation and family interactions and stuff like that. With the hyperactivity side of things, this can be that it's difficult for you to sit still, to inhibit certain types of action. Maybe you want to go and do something, so you need to do it right now, or it's never going to happen. And of course, if you have both of these, you can have sort of, you're paying attention to everything, and that means that you want to now go do everything, and you're kind of almost stuck with too many decisions to make. There's all sorts of bits and pieces you can pull apart there. But yeah, of course, it's going to end up having some effects on our day-to-day life. If people don't understand that that's what's going on, you might have things like, I have wandered off in the middle of a conversation, but it's not because I wasn't listening, it's because something else came up and I forgot we were having a conversation. And if people don't understand that's what's going on, it can put strain on those relationships. This is something that has genetic predispositions, and those genetic predispositions can actually make it difficult to diagnose this disorder. The reason for that is usually it's recognized when you see atypical behaviors. But if your parents have this disorder, what is atypical for them is not what would be atypical under this diagnosis. For them, wandering off, being distracted by stuff might be the normal, so they might never realize that it's something that could be causing problems elsewhere. It's one of those reasons why, in some cases, especially when we have these genetic components, they're often recognized in school rather than at home. Because in school environments, you don't have that sort of background of everybody in our family does this, therefore it is not atypical. But again, if we're talking about these usually being recognized early, that's sort of that school age. And then again, I've mentioned before, but both of these disorders have been traditionally studied in male populations, and both are often talked about as being predominantly seen in males. So you'll have something like, I think it's like 70% male in autism spectrum disorder. But as they've started doing more research with sort of an equal gender distribution, they're starting to realize that the expression of similar underlying symptoms is very different across the sexes, and therefore they've had to make dramatic changes to the criteria for this diagnosis. So that's something where we're seeing a pretty dramatic shift. And of course, with that shift, you're seeing later life diagnoses because it was something that would have been missed earlier on. So that's why I had my little complaint about neurodevelopmental disorders as a category. All right, trying to minimize the tangents, getting into schizophrenia. And this is, again, one of those topics where we talk about schizophrenia on its own because it is pretty much universal. We've seen this around the world in very similar rates. So our rate of occurrence here is going to be similar to rates of occurrence in tons of other cultures as well, which gives us that strong understanding that there's a genetic component. But because of that, and because it is fairly common, and when it's present, it's something that's easily observable because it has a dramatic impact on an individual's behavior, it has been widely studied and studied extensively for decades. So we have tons of research here. And you will notice that at a certain point, we're going to have to change the way that we talk about this. Once again, because the switch from the DSM-4 to DSM-5 completely rewrote how we talk about schizophrenia. So first off, what is schizophrenia in case we haven't gotten there yet? But this is where we have severe disturbances in thinking, speech, perception, emotion, behavior, basically everything. And this sort of extensive list of effects is why it's something that's fairly visible and why this is something that's fairly commonly diagnosed. It's not something that's often missed because it has those wide-reaching effects. We'll often see it associated with things like maybe delusions and hallucinations if we're experiencing sort of excessive or increased symptoms. We do actually end up finding that with schizophrenia, we either have too much or too little of each of these categories. So thinking, it could be excessive thinking or slowed or like depressed amounts of thinking. Speech, too much or not at all. Emotions, over emotional or no emotions. And that's actually one of those major overhauls we've done. But first off, delusions. Delusions are false beliefs that are going to be sustained despite evidence that would usually show that they're not the case. So if we have someone with delusions of grandeur, that would be somebody who assumes that they're really, really important, that they are the center of everyone's focus. So this could be someone who maybe is thinking that someone is out to get them. That would also tie in with delusions of persecution, where that's being targeted, they're being persecuted, that could tie because they might be persecuted because they're so important. There can be all sorts of other types of delusions, but all of them link together on the fact that this is some kind of false and extreme belief that's not founded in reality. And when we start looking at where could this maybe be coming from, these are sort of increased thought patterns that can maybe run away with them. With hallucinations, this is when we have false perceptions that feel real. And interestingly, with hallucinations, these aren't exclusive to schizophrenia. Hallucinations are actually a lot more common than we would have thought. If you haven't slept in a while, you are much more likely to have hallucinations. Sometimes, if you're, say, sick, you might hallucinate. And sometimes we extrapolate incomplete information from our environment, think we see something when maybe we didn't, that could still fall under this because there was that false perception. It felt real, but it wasn't actually there. So in this case, it's all about what's going on in our brains. Are we having activation for those particular senses? Usually we talk about visual hallucinations, but auditory hallucinations are very common with schizophrenia. So that could be sort of internal thoughts that are interpreted as actually external or separate voices. That's one of the theories on why auditory hallucinations are so common. It's a misattribution of our internal monologue, perhaps. But also we can have things like innocuous stimuli in the environment flagged as really important through some of those filtering stages coming into the brain and are therefore given extra significance, and maybe we interpret them differently than we should. So those are some possibilities there. When we look at the old way of talking about this, you've probably heard the terms paranoid schizophrenia. So that would be when we see things like our delusions of grandeur, delusions of persecution. So they are showing symptoms of paranoia. That used to be one of the categories. So if the main symptoms that were being experienced and were causing the most problems were all about these delusions and sort of false beliefs about what's going on in their world, that would be the label for it. Disorganized schizophrenia is another one that you might have seen. So this is when individuals show a lot of confusion, maybe incoherence in their speech. So they talk a lot, but it's not making a lot of sense. That would fall under this category. Then we get catatonic schizophrenia, which is when you have severe motor disturbances. So in a catatonic state, individuals might not move at all. And in some cases, they might have things like if you pose them in a particular way, they will hold that pose. They have no need to move. They're showing underactivity in terms of movement, so they just stay however they're positioned. And then, of course, undifferentiated means that it falls into either all of the categories or none of the categories or some subset of those categories. And it was surprising how many individuals showed a bunch of different types of symptoms. Though they did start finding a new pattern, which is why we went from these outdated subtypes of schizophrenia to the new subtypes with our DSM-5, which are just type 1 and type 2. Here, type 1 of schizophrenia is predominantly made up of positive symptoms, too much of something. So delusions, hallucinations, you are seeing stuff that's not there, thinking things that are above and beyond reality. This can also include things like talking too quickly. This can be excessive movement. Maybe they feel compelled to be moving all the time. So this is all about extremes to the too much side of things. We can also then see with type 2, this is going to be our underexpression. So predominantly our negative symptoms where we are absent our normal reactions. So you don't move, you think slowly, you talk slowly or not at all. You might lack motivation and emotion. Things like that might be underexpressed. And the reason why they started making this classification is because once we started being able to treat schizophrenia, which we get to talk about in terms of antipsychotics, they found that they were really, really effective in treating all of our positive symptoms. So individuals that were showing excessive amounts of behaviors were often going to respond very, very well to antipsychotics. But individuals with negative symptoms almost never responded to those antipsychotics. And when they started looking at some of the biological underlying mechanisms, the type 1 schizophrenia diagnoses, they often have certain imbalances. We'll end up talking about our dopamine hypothesis of schizophrenia, but that seems to hold very nicely for all of our type 1 individuals, but very few, if any, of our type 2 individuals. So they found that our understanding ended up being really, really good for positive symptoms, and then negative symptoms were stuck. And that once they started doing that, once they made that separation, all of a sudden we had very few of those uncategorizable individuals, which worked out really nicely in our favor. Now, I have borrowed, as always, from a different source, our sort of type 1 versus type 2 symptoms and some of our descriptors here. So how do they respond to our antipsychotics? Here they're calling them anti-dopaminergic drugs, and that's because they're sort of inhibiting excessive levels of dopamine. So our type 1s, they're going to respond well to drugs. With that treatment, they actually can find that those symptoms can be controlled. And once people start positively responding to treatment, they can often go back to their everyday lives. In these cases, are positive symptoms, even though on the surface they seem a lot more impactful, a lot more negative in terms of day to day functioning, they respond better to treatment and remain controllable for longer. They're also, even if left to their own devices, they might be something where you have an instant, sort of that moment of positive symptoms, that then go away on their own, or they might go away with treatment and never come back. They can be lifelong, but if with modern treatments, that's something that can be continually treated. Older treatments, not so much, and we'll do that later on. But yeah, so in this case, those are potentially reversible. But with our type 2, the negative symptoms, very poor response to those antipsychotics, the symptoms tend not to respond to treatments of any kind, and once they've gotten to a certain point, they're often irreversible. And we start seeing that those negative symptoms are actually associated with deterioration of brain matter. And that might be tied to things like long term or permanent intellectual impairment, also problems with cognitive processing and things like that moving forward. So those negative symptoms tend to have longer effects. They tend not to be something that's going to show spontaneous recovery. They don't respond well to treatment. So these, even though they are not as outwardly disruptive, because a lack of movement or a lack of sort of talking is not something that disrupts others, but it has a much longer term and detrimental effect on the individual overall. For most of this, we're going to skip over a lot of the specifics because this is mainly me having collected a bunch of cool graphics on schizophrenia. But what we're looking at here is a bunch of different bits of information that show that schizophrenia has a very strong biological component. Specifically, if we start looking at, say, this is concordance rates between our identical twins, at least for some of these, we're saying that if you have an identical twin, their other twin, or if you have an identical twin with schizophrenia, their other twin, their co-twin, is much more likely to also have schizophrenia than if we were looking at someone without schizophrenia and their co-twin. So our identical twins, as always, are much more similar. For some of these down here, looking at cumulative risk of schizophrenia in relatives, this is basically saying that our top line with the squares, if you have a family member who has schizophrenia, individuals within that family line are now more likely to develop schizophrenia themselves. So in the controls, so in the general population, if you don't have a direct relative with schizophrenia, your risk factor is about 0.5%, maybe up to 1% risk. But if you have a family member, that rises pretty close to like 7 to 10%, depending on which study you're looking at. At the bottom here, they're doing biological relatives versus adoptive relatives. So this is an adoption study that basically shows that you are unlikely to be similar to an adoptive parent in terms of schizophrenia diagnosis, but you are very likely to be similar to a biological parent. So even if you're raised by somebody else who doesn't have schizophrenia, having a parent who had it still puts you at very high risk of developing it yourself. And if we do our standard breakdown of our concordance rates, identical twins are going to end up being very, very likely to share a diagnosis. So if you are a twin, an identical twin, if you have schizophrenia, your co-twin is almost 50% likely to have it themselves. And as we move down, so a fraternal twin is much less likely to have it, and it keeps decreasing in our standard biological contribution pattern. And then this one is just really, really neat here, where if we have, so for identical twins, this is looking at the likelihood of their children developing schizophrenia. And so we're asking if our schizophrenic fraternal twin, so we have fraternal twins and one who themselves had a diagnosis of schizophrenia, they have kids, how likely are their kids to have schizophrenia? Vary. If the fraternal twin does not have schizophrenia, so their co-twin does, they don't, they have kids, their kids are not at increased risk of schizophrenia because the fraternal twin didn't show those symptoms, so it's unlikely that they had as many genes to pass on. But if you look at a identical twin who has schizophrenia, their kids are very likely to have it too. Even if they have their co-twin did not get the diagnosis of schizophrenia because they share 100% of the genes. So that means that the reason why they didn't have schizophrenia is likely some environmental influence. That non schizophrenia diagnosed twin is still very likely to have children with schizophrenia. Now, I will point out at the bottom, like it seems really extreme to be all the way to the end, but this is just still like a 16% risk chance, much, much higher than out in the general population. But it does show, again, that genetic component is very important. So whether you interpret all the graphs or not, we're just keeping in mind the fact that strong genetic components, the genes are going to have a very strong influence. Environment can play a role, making you more or less likely to develop it, but the genes are the most important component. And I've already said our dopamine hypothesis is the one that we typically talk about. So this is the idea that schizophrenia comes from high dopamine levels. And again, this holds true at least for our positive symptoms for type 1 schizophrenia. They've mentioned that this might be due, or that might have an influence on some of those hallucinations. So they call it the aberrant salience hypothesis. So those increased levels of dopamine might make us overly sensitive to incoming information. So our attentional and motivational circuits might react to things that shouldn't be flagged as important. Um, so we also do see that some individuals will have dopamine deficiencies and still have a diagnosis of schizophrenia, but that is very often individuals with type 2 schizophrenia. So before we made that distinction between type 1 and type 2, people were left wondering, why is this so perfect for some individuals and completely wrong for others? Now we have a better understanding. Some of our biological factors. So even though our dopamine theory doesn't quite work for everything, they have expanded on it. Something called the glutamate theory basically ties in the fact that yes, dopamine plays a role for some individuals and shows a predictable pattern, but if we go backstream, there are a lot of different pathways in the brain where the production of something in one place can influence the production of something in some other place that can influence the production of something somewhere else. And in fact, upstream from where we see dopamine levels affected, we also see glutamate as part of that pathway. And if we look at glutamate levels, those tend to show predictable patterns. So it still holds for the individuals with positive schizophrenia because it gives us a predictable over representation of dopamine. But fluctuation in that glutamate might help us understand where the negative symptoms are coming from. So that's why they think this might be a better and more complete explanation, because there are potentials to link it to negative symptoms. And because it already explains positive, now we get both positives and negatives. One of the problems here, and one of the reasons why early on treatments of schizophrenia were especially problematic, our first generation antipsychotics were extreme. And instead of just modulating dopamine activity, they actually effectively shut down our dopamine receptors. And by doing so, if you did that for long term, if you had positive symptoms that weren't going away, after time, you would actually cause all of these dopamine receptors to stop being produced. And once we have non-functioning dopamine receptors, our brains aren't responding to this neurotransmitter at all. So what we should have been trying to do is modulate the activity, sort of reduce it, but not make it go away completely. But the early antipsychotics were sort of a blanket effect of let's just stop all of it. But of course, dopamine is really important for stuff like fine motor control. And in fact, dopamine imbalances can be tied to things like Parkinson's disease. So we have something called tardive dyskinesia, which is when you've been on those first generation antipsychotics for too long, and it ends up cutting off a lot of those functionings in our dopamine receptors, you start seeing involuntary movements and tremors. And this ends up being a long term effect where even if you go off of those antipsychotics, the damage has already been done. And we see long term changes in how your brain processes dopamine. So, this is something that was really not great. Though at the time when they were first sort of put out to market, there wasn't an alternative. This was the only way to treat schizophrenia. And because it was such a clean treatment to start, it was used very widely. It was really important. It actually drove that switch from institutionalization to deinstitutionalization because you could be given these pills and sort of left to function in society, but those long-term side effects caused problems. And so, with time, our second generation antipsychotics, those dopaminergic or anti-dopaminergic drugs that we mentioned before, they actually ended up getting the best of all the worlds, where it's more specific to the areas affected by schizophrenia. So it's not blanket targeting all of our dopamine receptors, and it modulates, not completely shuts them down. So we actually end up with sort of not having tardive dyskinesia, but also having more effective treatments. Usually you end up with a trade-off of, well, we've accounted for these really extreme side effects, but as a consequence, our treatment is less effective. In this case, we actually get both. We get more effective treatment and fewer side effects, which is fantastic. So that's one of those reasons why this is an area of massive improvement. But a lot of that does come from the fact that it's been extensively studied and people have been looking at this for decades. In this case, we're starting to see some of the other effects, so biological effects here. So our ventricles are going to be basically the empty fluid areas within our brain. So these are areas where nutrients and stuff can move between areas. And if you think about it, they're open spaces that are fluid filled, they are not brain matter. So if we see individuals with schizophrenia having larger ventricles, it means they have fewer neurons because the open spaces are larger. So that's how we know that there is decreased brain mass associated with the negative symptoms of schizophrenia. The reason why the diagrams don't say that is because this study was done before that distinction. So they just talked about schizophrenia in general. So these patterns would have been influenced by the fact that the negative symptomed individuals would show that loss and others might be sort of not showing loss at all. When we also start looking at things here, so our prefrontal cortex, this is something that can show underactivity with individuals with schizophrenia. Basically, they show more impulsive behavior and they struggle where if you teach them to follow a certain set of rules for a while and then switch those rules, they hesitate. It takes them longer to learn that change than individuals without schizophrenia. And then just one more interesting and weird thing is there is a correlation between the severity of the flu season while your mother was pregnant with you and your likelihood of developing schizophrenia later in life. So they've done extensive longitudinal studies looking at things like, okay, if there was a really severe flu season and you were born after having gestated through that really bad flu season, you are at higher risk of schizophrenia as compared to someone who was born a different year. And this holds in different areas because sometimes you'll have worse flu symptoms in one part of the world and not others. So they'll find that those increases are only in the areas that were most strongly affected. Very, very interesting, just mentioned sort of in passing. And again, old data, so this is back in the 90s. So not that it's bad, but that they didn't have our current separation of positive versus negative. So we don't get any patterns here for modern diagnosis. Environmental factors, even though we focus so much on the biological and the fact that we have some mechanisms we can point to and stuff like that, we do, of course, have environmental factors. Things like illness can affect your development, but we can also look at, say, stressful life events. So the more stress you're under, the more likely you are to express this disorder. same as our usual discussion of our diathesis stress model. You can also have high reactivity. So individuals who are, say, high in neuroticism, that can also put you at higher risk of schizophrenia. And of course, we're not saying any directionality here. It's not like being neurotic makes you schizophrenic or vice versa. The two just tend to correlate. So it could be that that higher reactivity puts you under greater stress over time, which leads to higher likelihood of that diagnosis, but the mechanisms, that pathway isn't really well known. We can also find that family dynamic can have an effect here. But again, I will note that if we have a high biological component to schizophrenia, those in your family are likely to also have either that diagnosis themselves, or, because we've talked about things existing on a spectrum, things that are not quite qualifying for that diagnosis, but are still fairly schizophrenia leaning behaviors. So that instability in behavior might influence instability in the family home, which then you're not sure, is it the instability in the home or is it the biological contribution that increases your likelihood? So we can take these associations with a grain of salt. But that often comes with things like high levels of criticism, high levels of hostility. So you feel a lot more pressure in that environment, which could relate to higher levels of stress, which can increase your likelihood of development through that predisposition. And then a last point here, sociocultural factors. If we start looking at things like socioeconomic levels, so high versus low earning, schizophrenia is very common in lower income brackets. And there's two ways you can frame this. This can be framed as those who are in higher level, they're in more poverty, are more stressed, and therefore more likely to develop the disorder. But also, once you have this disorder, that can interrupt your life. It can make it harder to keep a job, especially before you get a diagnosis and treatment, or especially if you don't get treatment at all, that can cause you to drop in socioeconomic status. Because if you're not working, you're not earning enough money, which can then lead to higher levels of stress. So in this case, the two correlate, but we don't know about directionality, and it's probably actually a little bit of both. So it could possibly be one of those positive feedback loops. So it could either be called the social causation hypothesis if they're saying being lower income stresses you, or it could be the social drift hypothesis where having the disorder makes you learn less. Yeah, we already said minimal differences between cultures, so that doesn't have to be considered.